So, the group of people that I wanted to talk about that I think are othered very regularly by the healthcare system are probably the homeless. I used to work in the emergency room, and we had quite a bit of what you would call frequent flyers. And that was the first time that I really noticed that when somebody like that would come in, the nurses, the doctors, the patient care staff, everybody would kind of roll their eyes and be like, oh, X is back again, or blah, blah, blah is back again. Don't want to deal with her this time. It was almost like an immediate assumption that it was going to be the same thing that they've always dealt with. There's complaints about smells, sounds, disruptions. I think that the homeless are some of the most understood populations. Many are plagued with, mental health issues, substance abuse. Some just are down on their luck and in a bad situation. But time and time again, I think instead of finding the right resources for these patients, we kind of just go through the motions, do our job, and then put them back out in the same situation that they came from. I think that I personally probably hold the same bias as some of those people. I've caught myself a couple of times being like, ugh, not this guy again, and it kind of upsets me every time I realize that I do it. But I think that it's hard to kind of get out of that mindset. You initially think that, oh, it's their fault they're in this situation. They couldn't handle whatever. And now they're here, and now they can't help themselves. And now they're in my emergency room taking up the resources that I need for everyone else. And I think it's easy to forget that these people are humans and they have struggles just like the rest of us. And their conditions have only been worsened by their lifestyle. As one of the articles stated, 7.4% of disability adjusted lives are associated with drug abuse and mental disorders. So it's obviously really prevalent in every community. And bias that I've observed in both healthcare and community, I think, is much of the same. You're walking on the street and you see a homeless person, or you see somebody else see a homeless person, then they cross the street. It's that initial assumption that they're crazy, they're on drugs, they're violent. I think you kind of see that everywhere you go. I live in Chicago, and there's a large homeless population just a couple blocks from me. And I've actually seen interviews with these people, and they're just people just trying to live their lives. And the immediate assumption by both healthcare and just community members is that it is their fault, I think. And that is really upsetting and discouraging. Looking at the Croskery, I think that's how you say it, Croskery article. So because of the fact that we assume that these people are frequent flyers, right? We know that they're frequent flyers. We just kind of assume that we're not going to find anything new. Rather, they're just trying to abuse the system, get a place to sleep, get drugs. These are likely affected by something Croskery talked about as type 1 processing. So it's quick, autonomous, and you can really fall into that, seeing the same person over and over and over again. By immediately falling onto this type of processing, you can prevent reflection, right? Which is part of part 2 or type 2 processing, where you kind of have that slow, you process the situation, you use critical thinking, and without using this, you can lead to unexamined decisions, and that can lead to misdiagnosis or just generally having your blinders on, right? When you consider marginalization of frequent flyers, right, of homeless population, people with mental health disorders, substance abuse, every time we see a homeless individual, that confirms our bias, right? So it may not be one of your regulars, but a new homeless person comes in, and it's just the same stuff you're always used to, right? There's disruptions, maybe they're high at the time, or they're being uncooperative. In our minds, we're only further marginalizing that group because we're just maintaining those margins. It's almost causing you to put up your blinders One day if you have a patient who comes in and you assume that they're homeless, and maybe something else is going on. Maybe it's like acute psychosis that's caused by some sort of new diagnosis, but you just assume that this person is on drugs. There's a perfect example of how you're not failing to treat this patient because you just have confirmed your bias so many times and your blinders are up that you're having a hard time critically thinking and looking at the situation in a way to adequately treat that patient. They also have less resources. A lot of them have less education. And realistically, they have less ability to stand up for themselves because they've been pushed around by the system. They don't really feel like anyone's going to listen to them anymore. I don't think that people in this group experience equal care. Think about if somebody came into your clinic when you knew they had cancer or CRPS, complex regional pain syndrome, or sickle cell, and came in experiencing pain or a new symptom, you would immediately be going through all of the books, everything you can think of, trying to diagnose where this new thing is coming from. Whereas, like, if somebody comes in who's notorious for substance abuse and they come through, complaining of stomach pain, sure, you're going to do an assessment, but how thorough is that assessment really going to be? You know what I mean? The effects on this group is that they don't feel like they're helped. They're going to the emergency room. They're trying to find someone to talk to get the care that they need, and they're constantly ignored, right? And that furthers complications. It causes stress, anxiety, depression, increasing their already present health issues. And it really hinders us as well because we get so stuck in our bias that we apply it to every similar person, and we lose our ability to critically think, diagnose, and treat. If I could change the healthcare system, I think mandatory social work consults for all of these in the ED. I really liked the Madden article where they talked about the interprofessional outpatient intensivist teams. I thought that those were really awesome. They're there to help with coordination of interprofessional care for these complex patients, housing. They're just an ear to listen to. They're non-judgmental. They don't look at you and judge you for where you've been or what you do. They work in goal setting. And I think we really need to train our physicians and our nurse practitioners, all of our employees really, on a deep dive into mental health and drug abuse and like how big of an issue it can really be, because I think that people really think of it as not a health concern when it really is a health concern. Nobody woke up one day and said, I want to be addicted to heroin, or I want to get depressed and not pay my bills and lose my house. I think that educating our employees on the importance of what mental health looks like for these populations, I think that that's really important, just to kind of unloading that bias and giving them some kind of background knowledge on what these people go through every day.